Huang. I am the chair of the Department of OBGYN. And I just wanted to kind of go over a little bit about the format for tonight, and then I'll ask the remaining panelists to introduce themselves. So we're going to do this tonight in a webinar style, which means that really only the panelists will be able to be heard. We're going to ask for any of the attendees, if you have questions as the hour progresses, to feel free to use the chat function, and we'll have someone monitoring the chat box and try to get to all of your questions. Typically, we'll kind of go through some common questions that were asked in some of these forums. And again, I apologize on behalf of all of us that we're doing this virtually. In the last year or so, we've had to be very creative in how to be able to still maintain some sense of normalcy. And I know this isn't the same as the real thing, but we'll do our best to kind of get through questions and hopefully give you a little flavor of each of us. I will also kind of mention that this session is going to be recorded this evening. We'll be sure that we respect all patient confidentiality. And if for any reason it looks like names appear in the chat function, we'll either edit that out or we'll refrain from posting this. But I do want to kind of just mention that we are planning to record this and put it on our website so that folks can refer to it who aren't able to attend the hour session this evening. So with that, let me just start with a round of introductions. My name's Ed Huang. I'm the chair of the Department of OBGYN. I practice here at the Center for Women, and I've been here at Mount Auburn for approximately 10 years. I'll start with Dr. McKenzie, who's in my upper left corner. And I'll just remind the panelists that you're all on mute except for Dr. Hamlin right now. So you're gonna have to take yourself on and off of mute.
Yeah, my name's Kip McKenzie. I'm still in the clinic, so I've got other people near me. So I'm the masked person tonight, I guess. But I've been at Mount Auburn for now coming up 12 years. And I cover labor and delivery call. Unfortunately, not able to see patients prenatally in the clinic. So I'm up on labor and delivery very commonly.
Dr. McKee?
Hi, I'm Zoe McKee. I see patients in the clinic that Dr. McKenzie's in at the Center for Women located in the hospital doing general OBGYN. So I see a lot of you for prenatal care and then also take call on labor and delivery. And I've been here coming up on 5 years.
Thanks. Dr. Brown?
Hi, I'm Carrie Brown. I've been at Mount Auburn about 5.5 years now, and I'm just in the hospital.
Great. Dr. Hamlin?
Hi, I'm Cheryl Hamlin. I'm also a laborist like Dr. Brown. And I've been at Mount Auburn a good long while.
Dr. Steffley?
Hi, I'm Erin Steffley. I work at both the Center for Women location as well as Harvard University Health Services, and I've been here for just about 2 years now.
Great. So we'll have a few other panelists join us, and I'll have them introduce themselves when they join us. I know that they are still hard at work seeing patients in the office. So I'll start with the first question, and I'll pose it to Dr. McKenzie. What do I do when I think I'm in labor? Where do I go? Where do I park? Where do I come in? What are the logistics for what happens when I think I'm in labor? You're still on mute, Dr. McKenzie.
I'm clear on the concept now. Here we go. There are basically two timings to that. One is, it's during the daytime where basically you can call in to the usual clinic number, and they will then send that out, and people will be able to talk with you at the time to figure that out, whether it's time to come in or not. Some of the questions will be how frequent are the contractions, how long do they last, what's the intensity of them, is there leakage of fluid, and the other critical question is that what is it called, the group B strep culture, is that positive? So a couple of other details they'll ask, and then direct you to come in. And generally, if it's during the day, normal business hours, you're coming in, checking in up to labor and delivery, where the triage unit is, to check things out. So that's sort of a notification that comes through the usual clinic numbers and telephone calls. Then after the office is closed, somewhere around 4 to 5 o'clock, or certainly on the weekends, then that same office number is the number you call, but that number is, or the call is shifted to the sort of the coverage, the call coverage. And we get a page that you have called, and we call you back and asking some of the same questions, and then directing you to head on in or wait it out a little more and give us a call back, whatever. And if we direct you to head on in, then really you're coming through on, quote, the weekend, where the access is pretty typically going to be kind of through the emergency room if it's later at night. Alternatively, during the day, it's coming through the front desk, seeing the people at the front desk, and be directed up to labor and delivery once again, generally to the triage unit, which is right there on labor and delivery. And so again, it really, and the only really sort of a little slightly different, more difficult access for everybody is when it's late at night, after 8 p.m. at night, where all the front doors are closed, and you really have to route through the emergency room. Coming through that emergency room exit, it's to the west side of the hospital, and you can park the car there. You can come back and pick it up later. But that's the avenue through which you are directed up to labor and delivery through the ER. So if I, where you park is where you park, and better to do it in the parking facility. There's some, you can get a punch ticket to be able to get the parking there, so it's not off site anywhere.
Great, thank you. Dr. McKee, I don't even have to tell you what my favorite question for you is, but what should I bring to the hospital? What does the hospital have for me, and what will I need to bring?
So what I say every time, which is why this is my question, is you can tell the difference between a first-time mom and a second or third-time mom by how big the bags are. So you really don't need a whole lot of things when you come into labor and delivery. And we really have almost everything you could possibly need. So, you know, labor and delivery are messy processes. You can certainly bring whatever you want to wear in labor. Whatever you wear in labor may not be wearable again. So keep that in mind, which is why we usually give people gowns to wear during labor and delivery, and they can be worn the whole time you're here, or you can wear your own clothes at any point in time. So, you know, whatever you need for a couple of days while you're here. You know, most people, once they're here, learn the joys of the postpartum mesh underwear and leave with a stash of that mesh underwear in their luggage with their own underwear unworn. But you can, you know, bring whatever you need. The main thing that people forget that they wish they had geez, it's been a long day, which they wish they had with them, is a phone charger. That is the main thing that you need that we don't always have for you, although we do still have some of those as well. So, you know, other things, obviously a toothbrush and things like that, which if you forget, we have. You know, whatever your favorite, you know, mouthwash or face cream is fine. So, you know, the usual things, but you don't need a whole lot of other things that make you feel comfortable while you're here, which is usually just a couple of days. And, you know, if you're coming in for an induction, maybe some things to keep you busy, your iPad and things like that. You know, some people will bring in breastfeeding pillows, which you certainly can bring, but, you know, you don't have to lug all of that stuff in. We can help you prop up with pillows and figure that out while you're here. You don't need to bring your breast pump. We have breast pumps here if you need a breast pump, although if you want to, you certainly can. And the main thing that you absolutely need at some point is the car seat, because you are required to have a car seat to take your baby home. Other than that, we pretty much have what you need when you need it. And, you know, you don't need too much stuff while you're here.
Thanks, Dr. McKee. Dr. Brown, I wanted to ask you, who will care for me in labor, and what are the chances that my doctor will be here?
All right, so we have, a whole team on labor and delivery. When you come in, initially, often during the day, you might first see one of our labor and delivery nurses and one of the midwives in triage. So often they'll be the ones to sort of first assess you. And then it's a little bit, luck of the draw and who is taking care of you in labor. We all take turns being on call for labor and delivery. And so, sometimes people get lucky and see their doctor from the office, but that's not always the case.
Great. Dr. Hamlin, what's the difference? Dr. Brown mentioned something about midwives. What's the difference between doctors and midwives, and how do I know who will be caring for me?
So usually that is something that you would decide prenatally. And so I guess to preface how you would decide that, the biggest difference between midwives and doctors, and there's a huge overlap, is that midwives do spend the bulk of their time, of training, learning how to take care of normal labor. And while, the doctors do plenty of that, but we definitely spend a larger chunk of our training on how to deal with more complicated pregnancies, labor, delivery, as well as, operative things. So if you need any assistance or cesarean, we're there to do that. So you may, start out with a very normal pregnancy and feel like, oh, I want to have things as natural as possible. And a midwife would probably be an excellent choice for you. And then if things change, either prenatally, say you develop something, diabetes that requires insulin or something like that, you may then prenatally transfer to be a doctor patient. Or you may arrive in labor and delivery with everything, fine, or, and they can take care of some things, like they might take care of you with diabetes that you don't need insulin, or, they can manage high blood pressure. And, there is certainly a lot of things that they can manage. But, you show up to labor and delivery and you've been a midwife patient, that's great. We, definitely talked amongst ourselves. We know who's on labor and delivery. So there's, very little surprises. And then if you do need something, whatever that might be, just some, another head to kind of figure out what's going on, or say you do need a cesarean, then they would consult us, and try to do it both as early, but also unobtrusively as possible. If everything is going fine, you'll probably never see a doctor. And if there's a reason to think something might be going on, we might introduce ourselves and not really do anything, just say hi. But I will say that, compared to other places I've been, sort of the transition between midwives and doctors is very seamless. Like I say, as we all talk amongst ourselves, who's on labor and delivery and who might need what. And we're very available to introduce ourselves, like I say, and end up not doing anything because you don't really need us, or whatever it is. But most people have an idea of what they want to do, who they want to take care of them ahead of time, and then we adjust as time goes on.
Thank you. Dr. Steffley, I wonder if you could talk a little bit about what's changed from the patient's perspective on the labor floor because of COVID. What happens with the number of support people we can have? What about visitors? What has COVID brought that I can kind of expect to see differently?
Yeah, so there have been a couple of changes due to COVID, and some of these have kind of changed over time. One change is the masks. Again, I'm in the office today and sharing an office, so I apologize for still being masked here on this forum, but we do ask that patients and their support person wear a mask especially when any providers are in the room on labor and delivery. We currently allow 2 support people during labor and delivery. You're allowed 1 support person who can stay with you on postpartum throughout your stay, and a second support person who can come to visit during one visitor per day during some predefined visitor hours on postpartum. I think that upcoming, we have a change where we're going to allow this postpartum support person to come and go from the hospital, but I don't think that's gone live yet.
Yeah. No, thanks, Dr. Steffley. So I think that, I think a couple quick qualifiers. I mean, I think obviously we want your support people to be healthy. I think that that is something that we share with you to make sure that, our patients and their new additions to their families are as safe as possible. And we're trying to be kind of responsive to what we're seeing in the community from the COVID perspective. So we're seeing less COVID, we're seeing more people who are vaccinated. And so now we're trying to relax our restrictions a little bit. And, it used to be that when you came into the hospital together, you would kind of stay together during your whole hospital stay. Now we're allowing support people to come and go. I think sometimes people have another child at home, they have a pet at home, they want to go out, they forgot to bring something, so they can come and go. But I think each time you return, we're going to screen and ask the same questions of you. So we ask you to be patient as we ask you the same questions over and over again. Do you have a fever? Have you had any loss of taste or smell? Just the general questions that we ask everybody. You are allowed to have a visitor with you to our ambulatory visits. You are allowed to have a support person with you to your ultrasounds. And again, we just ask that that person be healthy when they come. Dr. Kapitanakis, there's a question in the chat about nitrous oxide and whether or not that has changed in terms of availability because of COVID, and whether or not people are required to have a COVID test prior to being able to receive nitrous oxide. I don't know if you feel like you can take a crack at that one.
No, thank you so much. Nitrous oxide is certainly available, so COVID hasn't really affected its availability. As far as I'm aware, I don't think COVID testing is specifically required for the nitrous oxide, but certainly it is required prior to admission in the unit. I think that's pretty much the short version of
Right.
the
So,
short version.
so we are kind of encouraging COVID testing. I mean, no testing is mandatory specifically, but we do encourage all of our patients to be COVID tested when they come in labor, or if they have a scheduled procedure, to have it done, a few days to a week before a scheduled procedure. So for instance, if you're having a repeat C-section, we'll try to get that COVID test done 2 or 3 days before you arrive. And that's, to kind of help clarify if there are any changing scenarios in labor. So, sometimes people develop a fever in labor because their water's been broken for some time. We'd love to just be confident that it's, related to pregnancy or the labor process, and not have you have to worry about it, or not have us have to worry about the possibility that it could be COVID. So having done tests beforehand, it helps us in some ways. Relative to things like nitrous oxide, for those who don't know, nitrous oxide, otherwise known colloquially as laughing gas, is an option for pain relief in labor. If it's something that you haven't heard of or that you might be interested in, I definitely encourage you to talk to your provider in the office about that option. There are a few things that are exclusions for nitrous oxide, but generally speaking, most patients are able to receive it if they wish. We do ask, because it has the potential for aerosolizing, and if you had COVID, you could aerosolize COVID particles, theoretically. We do ask that you have a negative COVID test, and we will perform that when you're admitted. Sometimes there's a little bit of a delay between when we do the COVID test and when we get that result back. So we do have some patients who know they want to have COVID, in which case they will be proactive with their provider to have COVID testing done before they arrive, so that there's no delay when you get here. But if for some reason you haven't been able to get a test beforehand, and we would offer it here at Mount Auburn. You wouldn't have to go outside of Mount Auburn unless you choose. We do testing on the labor floor, and at some points in the day we have the ability to do more rapid testing, and some points of the day it might take 4, 6, or 8 hours to get the test back. So I think that that's kind of the answer to your question about nitrous oxide and COVID. Dr. McKenzie, I wanted to ask you a little bit about the fact that Mount Auburn is a Harvard teaching hospital. What exactly does that mean for me when I come in labor? Will I see students, residents? Do I have an option of whether I want them or not? How many different learners are there, that I will encounter? You're still on mute, Dr. McKenzie.
I'm not very representative intelligence that I can't figure this out. But anyway, we do have smart people coming in as students to learn. And importantly, we have all levels of potential learners in a given space like labor and delivery. But unlike some of the other hospitals, we do not have, importantly, residents. We don't have MDs who are still in 4 years of residency training for obstetrics and gynecology. We have third-year medical students from Boston University, occasionally a third-year student from Harvard, and we have a PA student through Northeastern. They rotate on labor and delivery, doing a 12-hour or a 24-hour session, wherein they are sort of a part of the flow and the activity of labor and delivery. That said, you will be given an option as a patient to allow a student to be with you. Importantly, they are there as their primary role is to get you ice. Their primary role is to do things for you that are supportive of you if you wish. And likewise, they join us in terms of listening to the discussion of labor and delivery options, management options, things like that. And then much like the reason I went into obstetrics and gynecology almost 30 years ago was because I actually, as a student with hands-on from my attending, actually it was a midwife, allowed me to feel the delivery of that first baby, and sort of for thereafter I was hooked. But we hope that there will be, we'll call it meaningful involvement of students, meaningful for patients, but also meaningful for the students themselves. But all of that will not be something, if you wish, will not be something that happens. No involvement is just as much a possibility, but certainly all the students welcome that very rich experience, and they actually can be helpful.
Thanks, Dr. McKenzie. So I just wanted to take a moment to introduce Dr. Mahoney and Dr. McCarthy. I'll just ask Dr. Mahoney to just briefly introduce herself, and then Dr. McCarthy to introduce herself after that.
Hi, I'm Bree Mahoney. I'm a OBGYN generalist. I work for Atrius, and I work out of the Watertown office.
Dr. McCarthy.
Hi, I'm Dr. McCarthy. Sorry for the delay. This is my excuse. So I am on the Atrius docs, and I work out of our HBMA Atrius Cambridge office.
Thank you. Dr. Mahoney, I wanted to ask you a question that came up in the chat. It's about epidurals, but I was wondering if you could just kind of give an overview of the different pain relief options that are available to our patients. And then the question specifically about epidurals is, is there a time where it might be too late to get an epidural if I'm undecided if I need one or I want one?
So the last part is the easiest part, which is if the baby is actively falling out of you, it is too late to get the epidural. But other than that, it's not usually. I mean, the main thing is that you have to be able to stay still for it, which can be hard later on in pregnancy. We don't expect you to know when the right time to get an epidural is. And honestly, as a mom of two who had 2 epidurals, I didn't know when to get one myself, even being an obstetrician. And the nurses are really there to help guide you if an epidural is what you choose to have. We also have nitrous, which can be helpful. You have to hold the mask on yourself, and that can be helpful to take the edge off sort of the top of the contractions. And unmedicated labor is definitely an option as well. We do have tubs and showers for people, kind of help them through that, and moving around, and the nurses are really happy to support you. I would say the biggest thing about unmedicated labor, and I apologize for my patients who may be here who have heard this before, but I think about unmedicated labor as like running a marathon. It's not something everyone chooses to do. It's an experience that some people really, really want, but it requires preparation. And so to be really successful with it unmedicated labor, I would definitely recommend doing classes and doing specifically classes for unmedicated childbirth, so you know sort of other things that you're going to do besides nitrous or epidural to kind of cope through that pain.
Thank you. Dr. McCarthy, can you just comment a little bit on the anesthesia resources and how readily available they are at all times of the day, nights, or weekends?
Yes, so we're very fortunate to have anesthesia readily available 24/7. They are a team of an anesthesiologist physician, a nurse anesthetist, and as well as they have student nurse anesthetists who are overseen by both the nurses anesthetist and anesthesiologist. So they are available for epidurals as well as scheduled C-sections and any emergency C-sections we may have. So that really enables us, I think, to provide excellent anesthesia care to our patients at whatever point you feel you may need it. And also, like I said, in emergency situations, we work closely with them. And so we are able to perform whatever procedures we need to do in, a quick fashion.
Thank you. Dr. McKee, I was wondering if you could talk a little bit about pediatric services. Is it important that my pediatrician that I've chosen be able to come to the hospital? What happens if my, baby needs some extra assistance from the pediatrician during birth or thereafter?
So with regard to pediatricians, you will be asked during your prenatal care, if you haven't already, about identifying a pediatrician whom your baby will see when you go home. And I tell all my patients, my mom advice about this is twofold. One, you need a doctor who takes your insurance, because you're already paying for the insurance, so you don't need to pay copays on top of your preventative care. Two, you want somebody who's convenient, ideally with free parking. Okay, you have to take this baby to the pediatrician constantly. It is not until the baby is 2 years old that you only go once a year. So convenience is very important. You do not need some fancy schmancy person at Children's Hospital who's going to cost $50 for a half an hour of parking. It is not worth it. You want a nice, normal pediatrician in your community to take care of your nice, normal baby. And in terms of a pediatrician who comes to the hospital, there are some pediatricians who do come to the hospital. But again, I don't think choosing a pediatrician for 2 days is worth 18 years, right? So you can certainly, if your pediatrician comes to the hospital, that's nice. If they don't, that's fine too. We have what we call house pediatricians who take care of your baby while you and your baby are here in the hospital. And then they will send the information to that outpatient pediatrician. You normally need to see the outpatient pediatrician anywhere from 1 to 3 days after you leave the hospital. So it is nice to kind of already have somebody picked out that you're going to go to. Everybody always asks me, how am I going to make an appointment? I don't know when my baby's going to be born. Of course you can't make an appointment. Nobody knows when their baby's going to be born. The pediatricians are used to this. It's fine. You call them up, you say, I just had a baby, and they get you in. And the pediatricians here in the hospital will send all the information so that it's there. That's for kind of routine. If your baby needs a little bit of extra help, we do have what's called a special care nursery or a level 2 nursery that currently supports babies who are 34 weeks and above. And we have a team of pediatricians who are specifically geared towards helping any babies who need a little additional help. You know, at 34 weeks and above, this is often babies who need a little help with their breathing, or a little help with feeding, or a little help with putting on weight, or a little help with their blood sugars, those kinds of things. And we have support for that. For very preterm baby, or preterm babies earlier than that, we don't have the appropriate facility for those babies. So if you were to have a preterm baby before 34 weeks, that would require us to transfer you to a higher level facility for the pediatric care. We have the new nursery, which is lovely and wonderful. If your baby does need it, hopefully you don't have to visit it, but if you do, it's very nice with a place for you to stay and private and all of that. So that's what we have for pediatrics.
Thank you. Dr. Brown, can you comment a little bit on, is there a nursery that I could send the baby to at night if I just had a really long labor and I'm exhausted? Does that exist, or is there only rooming in?
So there is a nursery, and correct me if I'm wrong, Dr. Huang, but we've been encouraging, especially during COVID, for babies to room in. But in extenuating circumstances, I have certainly seen the nurses, caring for babies when moms are, super exhausted. But there are, benefits in terms of bonding and encouraging breastfeeding to having the baby in the room with you sort of throughout your hospital stay.
Yeah, I think Dr. Brown's absolutely right. We have not closed our nursery. It is available. But again, I think during COVID especially, we have had less patients who feel comfortable letting their baby out of their sight. Now, sometimes we do encourage you to get a little bit of sleep, especially if you've had a really long labor, or it's been, more complicated than we would have predicted. So we do still have that resource that is staffed with nurses to be able to kind of watch your baby. And again, I do think that with COVID, I think less of our patients are availing themselves of the nursery than previously before, but we haven't eliminated that as a possibility. So Dr. Steffley, I wanted to ask you a little bit about a question in the chat, which is, if my support person and I are both vaccinated, do we still need to wear masks? What's the mask policy for our patients and support people in general? And does it change at all if, folks are vaccinated?
Yeah, so we do still ask that even if vaccinated, that the patients and support people wear masks. The CDC has recently come out with some new guidance for small gatherings with friends or family members, but in a healthcare setting where both the physicians, the nurses, and the patients are exposed to a larger population of people, we do continue to recommend mask wearing while in the hospital.
Perfect. And Dr. November, I think, is on call today, so he was just able to join us. Dr. November, I just want to give you a chance to introduce yourself, and then I have a question that I was hoping you can answer for folks.
Very timely. So I'm Marty November. I'm one of the OB hospitalists from Atrius Health. And so that means that I don't have a practice at Atrius or at Mount Auburn. I only see patients at the time that I'm on call. I did, however, work have a practice for a long period of time, as you probably tell from my hairline, and worked at Beth Israel for over 10 years in practice there.
Perfect. So Dr. November, there's a question in the chat about what are the recommendations regarding getting the COVID vaccine while pregnant? And I think that this is a bigger subject that probably requires a little conversation with your provider in the office, but maybe you could kind of just generally talk a little bit about the COVID vaccine and pregnancy.
Yeah, so I think, so the issue with the COVID vaccine is obviously we don't have a tremendous amount of data in terms of long-term effects. We do have, limited data, the initial trials, and did not intend to involve pregnant patients. They did have several that were involved. Those didn't show significant issues. Obviously, the greater concern has to do with people who develop COVID during pregnancy and the risks there, and those are pretty significant. And so the general recommendation is for people, if they're amenable, to get the vaccine to avoid those untoward issues. So in some ways, it's kind of a balance between sort of known risks versus unknown but likely low risks in terms of the data that we have to date.
Yeah, I'll invite any of the other panelists to comment on the COVID vaccine. I think we're getting obviously a lot of these questions in the office, but if anyone else wants to chime in on a response.
So I'm recommending it based on the recommendations of the American College of OBGYN and the Society for Maternal Fetal Medicine. And I'm encouraging my patients to go to those websites if they're interested in looking at the data. That's Society for Maternal Fetal Medicine and American College of OBGYN, where, they have some basic information, but also links to the actual data and the studies, if that's, of interest to you. I would echo what Marty said in the sense that, there's no long-term data for anyone. Like there's no long-term data for me, and so we have to kind of do this risk benefit analysis. And we know that COVID is bad. And the vaccines, although they weren't explicitly studied in pregnancy, we now have registry data for over 30,000 women with no increased risk of negative pregnancy outcomes and no increased risk of vaccine outcomes. And some data coming out about antibodies passing through the placenta and antibodies passing through the breast milk in women who've been vaccinated. So there's some ongoing discussions about if in fact it might be beneficial for the newborn, although it's a little too early to have that information. But listen, you got to be comfortable with it. And just because we say we think the risks outweigh the benefit, the benefits outweigh the risks of vaccination, you have to feel comfortable with that because you're the person who is going to get the shot. And so I think that, as more and more people get it, we're getting more and more data, and we'll continue to discuss. But I really try to direct people to safe, good places on the internet, which I think Society of Maternal Fetal Medicine and American College of OBGYN are in terms of balanced and evidence-based. If you find yourself on Google and the general internet, it's pretty terrifying, the disinformation that's out there. And I, of course, encourage everybody to talk to their doctor if they have questions. But there's no penalty, like if you don't get it, we're not like, you can't come here. It's really, it's your choice, and we totally respect your autonomy.
Great, thank you. Dr. Hamlin, I was wondering if you could comment a little bit about the distinction between hydrotherapy and water birth. There's a question on the chat asking a little bit about whether the water birth facilities are available now, given the COVID pandemic.
Well, so the difference between hydrotherapy and water birth is actually giving birth in water. And we do have a tub available for that. Hydrotherapy is just being in water during your labor. So whether that's sitting in the shower and having the water on your back, which can be very soothing, or sitting in the tub, a lot of women, even if they have no interest in a water birth per se, can get a lot of comfort from that. I know that we got a new water tub, and to be honest, I'm not sure exactly the status of it. I think it's available right now. But that's a very short-term issue. For the most part, the midwives are doing the water births. I mean, there's some sort of training that for the most part the doctors have not done regarding water births. It's not to say that it's unheard of for a doctor to do it, but in general, if that's your big thing, that you want to have a water birth, you probably would want to see a midwife. And there's some exclusion criteria that you can talk with your midwife about. but basically you have to have a relatively normal pregnancy and labor. But yeah, and I think right now, if there's any limitations, it's to the actual tub, not to COVID, I think.
So like most things, we've tried to be thoughtful about what we feel is safe for our patients and what we feel is safe for our provider and staff community. One of the challenges with water birth is that obviously it's in water, and so things get wet, and we know that personal protective equipment is less effective when it's wet. So we went through about 14 months where we suspended our water birth facility option, but we have now reintroduced that to be started in the next few days to week. We just got a replacement water birth tub. We had one that we've used for about 10 years, and it was leaking a little bit, so we had to get a new tub, and I think we're nearing complete installation, so it should be available for patient use in the near future. Like nitrous oxide, we do require a negative COVID test, and in this case, it's on admission, not within the last 7 days. So certainly talk to your provider if that's something you're interested in, and we can kind of steer you in the right direction. Dr. Mahoney, another question came up in the chat. Given COVID, I think it's a little harder to do childbirth classes, a little harder to have tours. Are there any alternatives for patients to see the facility? Are there any video tours? Are there virtual childbirth classes? How do patients get a little bit educated about the facility and what to expect in labor?
So I think both groups, both the Mount Auburn docs and the Atrius docs, have a letter that they've hopefully sent out to most patients that include the links to breastfeeding classes and sort of how they've changed with COVID. A lot more of my patients are doing virtual childbirth classes, not necessarily at Mount Auburn as well, which I think is fine. There are some slight differences that, for example, Mount Auburn has nitrous and other hospitals may not. In terms of seeing the facility, I'm going to go with Dr. McKee's approach, which is just to be blunt and honest. If you've seen one L&D, you've seen most of them. They look pretty similar. If you want to see ours from 2012, the video is currently up, the video tour. And then I think Dr. Wong can help me with this, but I think they just filmed another one, right?
Yes. So I'm just going to take over the webinar for a second and share my screen. Just kind of for purposes for folks to be able to see that this is the Mount Auburn website. You go on any search engine, you find the Mount Auburn website. If you scroll down to the obstetrical portion, there is a variety of resources, including this area on prenatal care on the left, where they have a bunch of the different packets that we used to hand people paper copies of, but because of COVID, we're asking you to kind of review it online if you have that ability. We still have paper copies if you wish. And this kind of talks a little bit about what to expect at different milestones in your pregnancy. In addition, if you look at our website, there is a virtual tour that was shot. Yes, that's true, in 2012. We have just shot a new virtual tour, which needs to be edited, and it will hopefully be ready in the next couple of weeks, and we'll replace this old virtual tour with a newer one. And then there's also on the website, if you look at newborn services, there is within the last 6 months, actually within the last 2 months, a video tour of the special care nursery. This is, state of the art, just constructed at the beginning of this year. It's a 10 bed unit. Each of the rooms is a private room so that the baby and the baby's parents can stay with them. And that's really the only place like that in the Boston area. So we're very proud to kind of be able to brag a little bit about that. And so I encourage you on your own time to look at this video at your convenience, and hopefully your baby will not need the special care nursery, but if for some reason you did, I think you will be very happy. The views are spectacular, and the amenities are really nice too. So let me shift to Dr. Steffley. There's a question about warm compresses to minimize tearing, and maybe that that touches upon a greater question about, you know, how often are episiotomies made? What kind of tearing occurs with a birth? Are there things that you do to try and minimize the risks of tearing? So maybe you could kind of answer that larger question.
Yeah, so I think that kind of starting prenatally, something that you can do to try to minimize your risk of a perineal tear is a perineal massage. And that's something you could talk more about your provider, but basically using any sort of lubricant or oil during the 3rd trimester to kind of massage the perineum and reduce the risk of tears. At the time of delivery, we do encourage warm compresses. The nurses have those available that they can apply to the perineum or the provider during the pushing process to reduce the risk of tearing. Episiotomy is not something that we do routinely at this hospital. We have a very low rate. I would need to look at the numbers, but a very low rate of episiotomy is only done when medically necessary. We also have a very low rate of both 3rd and 4th degree lacerations, which are those that extend into the muscle around the anus or through to the anus.
Thank you. Dr. Kapitanakis, we haven't really talked about cesarean section much today. I was wondering, you know, it's hard to predict sometimes that if a patient's going to require a cesarean section, but can you just talk a little bit about some of the reasons why people do have a cesarean section and whether or not that's something that's commonly done here at Mount Auburn?
Yes. So in general, our approach to cesarean is that we will do it, we will have a cesarean only if it's medically necessary and indicated, and not for plain convenience. So in general, our numbers here are pretty low versus the national standards. And you can help me with that, Dr. Wong. I want to say it's about 15%. Do I get that right?
Exactly.
Which
For
is
someone having their first baby, it's about 15%.
Exactly, which is a very low and acceptable percentage. So moving on, the usual indications for cesarean are what we would call the failure to progress or failure to descend of the fetus, which in plain terms means a dysfunctional labor that has had all its chance to move forward. It had enough time, enough medication to augment contractions, and for a variety of reasons, it's not moving forward. So given the appropriate amount of time, enough for sure after discussion with the mother and the family, we might proceed with cesarean. Other probably more common and fairly significant indication is what we call the abnormalities in fetal heart tracings, and that can be both an emergency when we have an significantly abnormal fetal tracing. In order to protect the fetal well-being, we will have to proceed promptly with cesarean, or an overall abnormal pattern of the fetal tracing, and sometimes that can be an indication. And if we are remote from a vaginal delivery, we can, most of the times we will do a cesarean.
Thank you. There's a question that I think could be asked for multiple providers, so I'll put it out there and see if folks would like to comment. So how do you as a provider feel about a natural unmedicated birth, and how do you support it? And this person writes that they would love to hear from several of us about kind of our philosophy about that. So maybe I'll start with Dr. November, and then I'll open it up to the rest of us to kind of comment on that.
Great. I was actually going to volunteer, so thank you. So first of all, let me preface this by saying, you know, that some people talk about having I know that people have some discussions, you know, with the providers around birth plans. The main focus in terms of our birth plan is for a healthy baby, healthy mom. Those are sort of two endpoints which we will never compromise. That said, you know, we also would love for people to have, you know, a quick vaginal delivery without any medication. That would be ideal. You know, we have, as we were just talking about, one of the lowest C-section rates in the state. That said, we still do, you know, roughly 1 in 5, 1 in 6 deliveries end in a cesarean. So we still have experience doing that, but our, you know, again, there are certain indications for that we're very clear about, and that we will talk with you about during the labor. In terms of trying to support folks, I would say that without question, you know, one of the main group of people that help support this are the nurses. So those are the people who are with you, you know, the majority of time during labor. And so, you know, we talk to people that there are a variety of different resources to help support you in terms of having an unmedicated birth, such as we talked before about the hydrotherapy that Dr. Hamlin mentioned. You know, so people going in the shower, people walking, people sitting on the ball. Those are all sort of, you know, what we call, you know, non-pharmacologic methods of sort of managing with the pain. In addition to the, you know, nurse helping support someone. You know, one of the things that I also say is, and this is as the father of 3 children, is that, you know, a lot of ways labor is somewhat, you know, similar to child rearing in that it, you know, you can have all the intentions that you want, but at the end of the day, sometimes your kids are just going to do what they want to do. And so I think that one of the things I encourage people to do is to be open to, you know, the experience in general, and that sometimes it'll go very quickly. And so I've had patients who, you know, had wanted to get an epidural and were actually frustrated because their delivery went too quickly and they weren't able to get it. And similarly, on the other side, where people, you know, really didn't want to get any medication or any sort of interventions, and because of what was going on, it necessitated it, and they were, you know, having significant pain, let's say at 1 or 2 centimeters, and were really, you know, benefited significantly from having some intervention. So, you know, I think, you know, again, we try and take our cues, of course, from you as the patient, but, you know, one of the things we also try and do is share with you what's going on medically, and, you know, make recommendations to the best of our knowledge and experience. That said, at the end of the day, those are, you know, that is, you have the, obviously the ultimate, you know, the end, the ultimate word in terms of that. So, you know, so we really, I can just speak personally that I very much see it as a partnership and trying to be collaborative, but of course there are some things that, you know, based on our experience and medically, that would necessitate interventions, and hopefully we'll do a good enough job explaining that'll be self-evident.
Others want to comment?
I would just say that, sorry. In general, I think we're very supportive of unmedicated birth if that's what you want. Our epidural rate at Mount Auburn is approximately 60%. So, you know, about 40% of women choose to not have an epidural for their labor and delivery. And that is a much higher percentage than a lot of our surrounding facilities. And so I think that gives us more experience, and primarily our nurses more experience with women choosing that in terms of the support. You know, in terms of how we feel, it's not, you know, about how I feel, it's about how you feel. And I completely support in whatever you want. And I will tell you, as a person who had one birth with an epidural and one birth without, it is a vastly different experience. And it has to do with the experience that you want to have. And we are perfectly happy to support you through that, if that is what you want. And I think we have a lot of experience and ability to support that.
Dr. Hamlin, you want to have another word?
Oh, yeah. I mean, I just wanted to reiterate what Bree said, Dr. Mahoney said earlier, that I think if having an unmedicated birth for you is important. It's something to plan for. I mean, there's all kinds of techniques to help you get through labor, including hypnobirthing and, you know, breathing and focusing and all of that. But you can't. It's hard. And I shouldn't say can't, but it's hard. It's harder to sort of come into labor without having even thought about it, and then suddenly say, okay, now I'm going to practice my deep breathing when that's not something that you normally do. So I would just say, if that's important to you, and it may or may not be, then think about it and think how you are going to approach this, and, you know, either take a formal class or talk to somebody else that's done it, or whatever you can to kind of prepare yourself.
So we've come up on the end of an hour, and I just wanted to kind of ask all the panelists to just reintroduce themselves in case there are attendees who joined us late, and just kind of remind us who you are, where you work, how long you've been here. So I'll start with Dr. McKenzie. Still on mute.
Yeah, no, I got it now. Yeah, I've been here long enough to know how to work this, but about 12 years. And I work down at Center for Women, and I cover labor and delivery. Sadly, I don't have the opportunity to see patients prenatally, but I'll see you up on labor and delivery.
Dr. McKee.
I'm Zoe McKee, and I am work at the Center for Women at the hospital. I see patients at the Center for Women.
Dr. Brown.
I'm Carrie Brown. I'm just at the hospital, and I've been here about 5.5 years.
Dr. Hamlin.
Hi, yeah, Cheryl Hamlin. I'm a laborer, so I'm just here at the hospital, and I've been here over 12 years.
Like you're a construction worker there.
I just have an outdoor seating.
Dr. Steffley.
I'm Erin Steffley. I work at the Center for Women and Harvard University Health Services, and I've been here for about 2 years.
Dr. Mahoney.
Sorry, muting issues. Bree Mahoney, Atreus Watertown, and I have been here for 2.5 years.
Dr. November.
I'm Marty November, Atreus hospitalist. I've been at Mount Auburn for about 3 years.
And Dr. Kapitanakis.
Theo Kapitanakis, working at the Center for Women at the hospital. I've been here for 3 months.
Great. So I want to thank all the panelists for joining us this evening. I want to thank all of our attendees. I'm going to politely ask for our panelists to go off and do the things that they would like to get back to. I'm going to stay on for another 5 minutes. There are about 4 more questions that we didn't answer, and I'll take those questions, and then we'll end our session for today. So thank you to the panelists, and we'll see you all soon. So there's a couple other questions that are on the chat for those attendees who want to stay on this call. There's a question about twins and being before 34 weeks. I will just say that there are a variety of reasons why, you know, people might deliver before 34 weeks. Happily, it's a minority of patients. If you were to have a condition that caused you to go into labor or need to be delivered before 34 weeks, we would likely transfer you to one of our sister hospitals that is a tertiary care facility that has the neonatology backup that would allow kind of support for your baby long term. We have all the ability to take care of any mom and any baby short term, and we have a staff of neonatologists. We just don't have all the ancillary services like nutrition and other services to help take care of your baby long term. So you would likely need to be transferred to another site. There's a question about plan for pushing after having an epidural. And I think, I guess I would have to say that that's a hard question to answer in general, because there are a lot of different circumstances. I think that, you know, there may be a patient who gets an epidural when they're 10 centimeters and they would be eligible to push, but they're exhausted. So they may rest for a little while. I think it all depends on how mom and baby are doing. we don't have any strict time limits or plan. I think it really depends on your individual situation and your individual course. And we try and tailor it kind of based on medical and kind of birth experience preferences. So I think that, that will kind of depend on what's going on in the situation. There's a question about a surge in number of there's a surge in number of women who are delivering on the same day, and there are no available beds and rooms. Will I be asked to go to another hospital? So, I think one of the difficult things, and one of the great things about labor is that, the baby kind of controls the timing most of the time, and we don't have a great way of predicting when you're going to have your baby. And I think that that's probably good, because we try to be less interventional and we try and let nature take its course. So, there is, a challenge in what we do, which is that babies don't come spaced out. They kind of sometimes come all at once, and then sometimes we get a gap without having many births. And so it's really hard to staff for situations where you have 3 times as much as you normally have on average, and and times where you have 3 times less patients than you typically have. Having said that, we fortunately don't have to divert patients very frequently. It happens once, twice, 3 times a year, potentially. And, we would, in a situation where we had too many patients or many complicated patients, the end of the day is like what Dr. November said, which is that we want to have a healthy baby and a healthy mom. And if we can't safely take care of you, we're going to get you someplace where they can safely take care of you. There's a question about breech presentation and what, when a patient would need to be concerned about that. Basically, by 36 weeks, 95 to 97% of babies have found the right position. So it isn't very likely that your baby will be breech after a month before you're due. And if the baby still is breech at 36 weeks, that doesn't mean the baby's going to stay in that position. But I think then at that point, you and your provider will have a conversation about what the appropriate next steps are. And, we offer the whole gamut of options for, situations where the baby would be breech. But I think that that's a situation I would want you to kind of talk to your provider in the office about. And then lastly, there's a question about whether this recording will be available to watch and reference later. And the answer is, we hope it will be. We do need to kind of go through this and make sure that we're protecting patients' privacy. And we have a recording. This is set up to record. And as long as patients' confidentiality and privacy is respected, we'll be able to post it to our website. And so we hope that you'll be able to refer to this at a later point in time. And so with that, I just wanted to kind of thank you all for joining us. Again, apologies that this is not in person. We hope in the very near future, we will be able to kind of be able to see you in person. We know that we're not yet good enough to do virtual deliveries, so we will be meeting you at some point. But unfortunately for today's forum, it has to be virtual. So thanks again, and we look forward to seeing you soon. Bye-bye now.